Understanding elbow instability. The elbow complex is inherently stable. Its articular surface is complex and precise. The objective of this presentation is to define elbow instability, recognize stabilizing components, and understand the main instability patterns. So what is elbow instability? It's when the elbow is unable to maintain articular congruity under static or dynamic circumstances. Why does it become unstable? Well, because there is failure of one or more of the elements that produce resistance to instability. And what are the structures that produce resistance? Well, like in any other joint, bones, ligaments, and neuromuscular structures. Particularly in the elbow, the geometric conformation is very important. It makes it a very tight and solid joint, especially the ulnohumeral joint, which is composed of the distal humerus, coronoid process, and olecranon. So the olecranon is not seen or relevant as a stabilizer of the elbow. We might have these big fractures of the olecranon and still the elbow is congruent, it's stable. While on the other hand, when we have fractures or big fractures of the base of the coronoid process, the forearm usually tends to dislocate posteriorly, and especially in these cases when we have an association of the radial head fracture as well. Why does this happen? Because the resultant forces of the forearm are always aimed posteriorly. So we need something like a coronoid process, a big piece of bone in front of the distal humerus, to stop this from happening. The same is seen with the radiocapitular joint. The radial head is also in front of the elbow, it's also like a big bumper, and it contributes to elbow stability in a longitudinal fashion for the forearm, valgus, and posterolateral instability. Ligaments in the elbow are extremely important, they are extremely tight as well. We have the medial collateral ligament, especially the anterior oblique band of the medial collateral ligament resists to valgus instability. And the lateral collateral ligament is a complex of ligaments. The two main structures here, they insert in the isometric point or center of rotation of the lateral humerus. And the ulnoradial ligament is important, and this particular oblique band or lateral ulnar collateral ligament is also important because it connects directly the distal humerus to the ulna. So when this ligament fails, it will not only give lateral instability, but also rotational instability. So the avulsion of this complex on the lateral aspect of the humerus will give posterolateral instability. There are a lot of muscles surrounding the elbow, the medial and lateral epicondylar and epitrochlear muscles, and also the known muscles in front of the elbow joint. But still, we have not determined as well how much do they contribute to stability, although we know they do something. Well, mechanism of injury. What are the different patterns of instability? These are maybe the main ones. Axial load, valgus and posterolateral rotation, pure valgus, and varus and posterior medial rotation. So the axial load is this one that happens when the distal humerus impacts against a great sigmoid notch, and when the force is significantly enough, with the elbow in 60 to 90 degrees of flexion, transolecranon fracture dislocations happen, and this is one of the instability patterns of the elbow. Valgus and posterolateral rotation is probably the most common one. It happens with the arm in extension, axial load, valgus supination. So what happens here with these mechanisms, with the supination and valgus, there's a stretching of the lateral collateral ligaments. The ulnohumeral joint opens up, and as this process progresses, it progresses from lateral to medial, although there are some surgeons who believe it's from medial to lateral. But as they happen from lateral to medial, the joint opens up as it rotates in supination. The trochlea is sometimes, the coronoid process is sometimes perched with the trochlea. Maybe the process stops there, but if the resultant force of the elbow is significant and the elbow flexes enough, then the elbow will dislocate in a posterolateral direction. Now within this same mechanism, when the coronoid process is perched, if there is not enough flexion and the resultant force is strong enough posteriorly, a fracture of the coronoid process and the radial head will probably happen, and this will generate a terrible triad injury. Pure valgus instability may happen because of overuse for throwing athletes, or simply by trauma with a direct valgus load. This patient had this type of injury of valgus direct trauma when he fell. So we can see the opening up of the medial side of the elbow, and in the MRI we can see an avulsed medial collateral ligament and flexor pronator mass, giving us an acute valgus instability without dislocation. And varus and posterior medial rotation is a bit more complex. There's varus, axial load, and posterior medial rotation of the forearm. So what happens here is as the elbow goes into varus, there's an impaction against with a medial facet of the coronoid process and the trochlea. Lateral collateral ligament is stretched, and as the arm rotates, there's a shear fracture of the medial edge of the coronoid process. So this will give us an anteromedial fracture of the coronoid, lateral collateral ligament injury, and an injury of the posterior bundle of the medial collateral ligament as well. And this is a typical X-ray view of this lesion. So for final considerations, every structure in the elbow joint contributes to elbow stability. Knowing each of the structure's functions will allow us to understand the deficit that it will generate when it is injured. So recognizing a pattern of injury allows us to know what structures must be repaired for an unstable elbow.